From the JAMA Network, this is JAMA Otolaryngology Head and Neck Surgery Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Otolaryngology Head and Neck Surgery.
Hello and welcome to our listeners from around the world. This is the JAMA Otolaryngology podcast series, and I'm your host, Dr. Paul Bryson from the Cleveland Clinic, where I'm the section head of laryngology. And today I'm delighted to be joined by Dr. Lauren Gabra. Hi, Lauren. Welcome to the podcast.
Hi, thank you for having me.
Dr. Gabra is a fourth-year otolaryngology head and neck surgery resident at the Department of Otolaryngology at the University of Texas Southwestern. And I'm also joined today by Dr. Baran Sumer. Welcome to the podcast, Dr. Sumer.
Thank you for having me.
He is the professor and chief of the Division of Head and Neck Oncology within the Department of Otolaryngology Head and Neck Surgery at UT Southwestern. And we're going to be discussing their recent article on body mass index and nutritional status with immunotherapy response in head and neck cancer. So thank you both again for coming on. You know, maybe it's cliche, but we do seem to be in the immunotherapy era with head and neck cancer care. I just wanted to open it up a little bit. Can you share with the listener what prompted you to explore body mass index and nutritional status in your head and neck cancer population?
Well, one of the things that's very common in patients with head and neck cancer is an inability to swallow and eat. They have significant dysphagia. They have significant amounts of pain. So weight loss is extremely common in these patients. In the past, we've noticed that patients who have a lower body mass index, who are nutritionally depleted, tend to do worse just from any sort of therapy, both surgical therapy, non-surgical therapy, when we're treating their head and neck cancer. And we actually looked at this and how it correlates to some of the outcomes we have from neck dissections. So one of the quality metrics for neck dissection is the number of lymph nodes that are removed. And we had noticed in our practice that those numbers were less in patients who had a lower BMI. And that actually correlated with worsened survival. And we showed that the worsened survival might not just necessarily be due to the inability to remove those lymph nodes adequately during surgery, but may be related to the fact that these patients were nutritionally depleted and that their lymph nodes had atrophied. And this is something that goes back to the literature that was observed back in the 1960s and 70s, that people who are malnourished tend to have smaller lymph nodes and fewer lymph nodes in their neck. And that led us to think about immunotherapy, where you're talking about a therapy where you're trying to get the immune system to get stimulated against the cancer and fight off the cancer cells. And the question is, if someone's malnourished and their immune function is compromised, is that going to compromise the effectiveness of the immunotherapy?
Yeah, I mean, it sounds like a great question. Tell us a little bit about the population that you investigated. Was it a particular subsite, or was it all comers, or who did you include?
So this was a very large database, and what we wanted to do was include basically as many head and neck cancer patients treated with immunotherapy as possible. So we utilized the Flatiron database, which covers over 5 million patient journeys across 22 different cancer types. And it actually involves multiple different types of markets. And it's a national database looking at hundreds of different centers that participated in registering their patients with this database. And we had access to essentially over several thousand head and neck cancer patients that had been treated with a variety of different treatments. And we basically selected for the ones that had had immunotherapy, defined as any sort of PD-1 or PD-L1 inhibitor. And we also included CTLA-4 inhibitors in that patient population. And we wanted to observe and see if there were any correlates or patient-related factors that might predict outcomes from that immunotherapy.
Yeah, I mean, that's a lot of patients. I'm not familiar with the Flatiron database. How complete is the database? You know, we do see some new database studies coming out, Trinetics and things like that. What do you like about the Flatiron database that helps you do these sorts of projects?
One of the nice things is that it doesn't just include academic centers. The Flatiron database actually includes smaller centers as well. So this is practices that may not be in tertiary care facilities. This may not be academic practices. This may be smaller, more rural practices. So in addition to having the large numbers that you would expect from a national database, you also have the ability to look at patients from diverse backgrounds. So it's not just going to be, patients in a larger tertiary care referral center. It's going to be smaller rural areas. It's going to be areas that might be underserved. So you're getting a nice slice of that head and neck cancer demographic that I think is a little bit more representative than some of the other databases that might be selecting for patients from a given type of practice.
Yeah, that's pretty unique, but sounds like it's a little more of a real life snapshot between some of the obstacles that patients may face just trying to get care. Not everybody can drive many, many hours to the tertiary care center.
Correct. And we wanted to include a lot of those types of patients because one of the emerging themes with immunotherapy is the burden of immunotherapy on these patients, because a lot of patients are often getting multiple treatments. And the length of the treatment is sometimes open-ended. We treat them for 6 months to a year, and they're coming in for intravenous infusions every 2 to 3 weeks for these therapies. So the burden of care is very, very important. And so those demographic factors that you alluded to start becoming very, very important with respect to compliance and things like that with the therapy, or their ability to actually stick with the therapy because of logistics, financial reasons, many other factors that play into this. And we wanted to control for all of that. We wanted to be able to actually have a representative group of patients that not just represented some of the patients who might have easier access, for example, to larger hospital systems, but also patients who may not have that access as well. And then some of those demographic factors go hand in hand with predictors of malnutrition. So in this particular case, lower BMI, but then also their P&I status, a more comprehensive measure of what their nutritional status was and what that might be doing as far as impacting their response to immunotherapy.
To take that a little bit further, Dr. Gabra, what did you find, but also how did you measure nutritional status from this database? What was available to look at?
So we primarily looked at baseline BMI. We also looked at change in body weight before starting immunotherapy. And we measured prognostic nutritional index. So that reflects protein status and immune cell levels. So we looked at that and we found no significant association for when we looked at baseline BMI. However, patients who lost 2% or greater of their body weight before starting treatment did have significantly worse outcomes. And similarly, if they had low prognostic nutritional index, they also had shorter progression-free survival. And we found it was 213 versus 566 days.
So pretty meaningful, right? As you look at your population, how many of these patients had feeding tubes placed? Do you have a sense from the database what interventions? Were people trying to fend off weight loss and lower nutritional status? Or is it just kind of, this is the nature of how they were doing in their disease?
Yeah, so that was actually one of the questions that came up while we were looking at this. We actually did not have feeding tube information on these patients, unfortunately. And obviously, one of the key things that happens when patients become nutritionally depleted, and different centers have different cutoffs for this, but if they're losing a significant portion of their body weight, most of these patients will get a gastrostomy tube or supplemental feeding tube for nutrition. Unfortunately, we weren't able to look at that or control for that. All we could look at was kind of the outcome, which was weight loss during that time, as well as some of the immune markers and other key metrics that we wanted to look at with respect to predictors of immunotherapy. And as Lauren pointed out, this was the prognostic nutritional index, which takes into account not just the patient's BMI, but also other factors, including their white cell count and other immune parameters.
It still seems like pretty important information, and it seems to set itself up for a prospective study where you're looking at when is the best point to try to rescue, right, weight loss and nutritional status. And can you speak to when you have a new patient that's going to start on therapy like this, are there things that, based on this sort of information, that people might do pre-treatment or at the initiation of cancer care to try to optimize the situation nutritionally as best as possible?
Yeah, that's a great question. Anecdotally, it's very interesting. There were some older studies back in the 1980s and 90s that sort of tried to look at nutritional optimization. And the question was, does that help for nutritionally debilitated patients? And I think the data was mixed. So there was no clear-cut benefit to a nutritional supplementation, although it makes sense if you can restore patients nutritionally and prevent them from losing weight and gain some weight, you would imagine that that would help their cancer outcomes, their healing from radiation or surgery. But it wasn't as clear cut as that. Then the question becomes, is there something where giving more nutrition makes cancers grow faster? Maybe you're feeding the cancer in addition to feeding the patient's immune system, or is this a race between the two? And so, one of the interesting findings or anecdotal things that I learned as a resident was sometimes you have patients who are nutritionally depleted and they get a gastrostomy tube, you start feeding them, and it seems like their cancer metastasizes or seems to spread or grow faster now that they're nutritionally more optimized. Very anecdotal. I mean, there's no data behind any of that, but it makes sense, right? So if a patient is malnourished, their cancer is malnourished, if you start feeding them, well, their immune function comes back, their healing function is improved, potentially, but then you're also potentially driving cancer growth and growth factors that may be responsible for that. So it becomes a little bit of a race between, can you restore the immune system faster, or is the cancer going to grow faster? And I don't know that there's a clear-cut answer to any of those questions. I'm not even sure if that's been demonstrated scientifically, but we do have some preclinical data that suggests that that is the case in mice from our lab. And we do have some preclinical data that suggests that different types of fuels may have different impacts with respect to how they stimulate the immune system, their potential benefits for immunity, versus how they may impact cancers. And one of the papers that we published a few years back was on lactate specifically. And what we found was that lactate actually increases the stemness of CD8 cells in mice with head and neck tumors, as well as other kinds of tumors. And what that seems to imply is that if you feed lactate as a fuel, you can improve immune function. You can improve the cytotoxic CD8 T cells that are responsible for anti-cancer immunity. But at the same time, you suppress tumor growth because of the high concentration of lactate. And the potential reason for this, and we showed some preclinical data on this, is that tumors are very acidic. The extracellular environment of cancers are very acidic. And that's due to aerobic glycolysis, which is the Warburg phenomenon, where cancer cells will take up glucose and preferentially secrete lactate plus a proton into the surrounding extracellular environment. So lactate plus a proton is lactic acid, and that acidifies that microenvironment. And the way that transportation occurs is through something called an MCT1 channel, a monocarboxylate transporter. And the transporter is essentially like a bidirectional passive channel where a lactate and a proton are exported from the cell into the surrounding microenvironment. It turns out if you increase the lactate concentration sufficiently in the extracellular environment, you stop that flux through the MCT1 channels, and you almost create a bottleneck for the cancer cells. At the same time, that lactate is a great fuel for the cytotoxic CD8 cells, and it improves their stemness. And we've shown that you can actually cause tumors to grow slower in mice when they are treated with lactate. And when they're treated with a PD-1 inhibitor, they are more responsive to the PD-1 inhibitor when they're given lactate simultaneously compared to control mice. So there's some preclinical data that suggests that potentially certain types of feeding strategies that might involve, for example, giving patients lactated ringers or lactate without the extra proton may improve immunotherapeutic outcomes. But obviously, all that's very, very theoretical at this point.
Thanks for that background and the explanation. As you kind of digest what you found in this study, what are some next steps and maybe some take-homes for the listeners as we look for more in this space?
So I think the take-home message is that we tend to get very involved with deciding the specific type of therapy for patients, where we talk about immunotherapy or chemotherapy or radiation or even surgery as kind of this monolithic one-size-fits-all treatment without taking into consideration that patients with different starting points, with different nutritional status, for example, or patients who have different levels of immunocompromise might be responding to these treatments very, very differently. And I think the patient factors that play into the success of oncologic therapy is extremely important. One of the main things about immunotherapy that's very, very special is that you're harnessing your own body's immune system to try to fight off the cancer, as opposed to trying to kill the cancer directly with, say, cisplatin or other chemotherapeutic agent or radiation or just removing it surgically. So you're actually relying on your own body's naturally evolved systems to try to take care of this disease. And in that context, as immunotherapy becomes a cornerstone of treatment for head and neck cancer, and it becomes more and more important for all of oncology, it becomes even more important for oncologists to understand the different levels of immunocompromise that may exist in patients, and for us to try to find ways to overcome that. Because if you're relying on the patient's own immune system, it makes sense that we should optimize that immune system before we embark on immunotherapy.
Well, I really appreciate your time today. Appreciate Dr. Gabra as well. We'll look forward to more impactful investigations from you and your group down at UT Southwestern. Thanks for coming on to the podcast today.
Thank you for inviting us.
Yeah, thank you for having us.
This episode was produced by Shelley Steffens at the JAMA Network. You can find a link to the manuscript in this episode's show notes. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.